Hi, my name is Sam Jones and I'm one of the CED consultants. In this presentation, we're going to discuss specific considerations for the 16 and 17-year-old population. Since the start of the COVID pandemic, 16 and 17-year-olds are now seen and treated in the Children's Emergency Department and, if appropriate, are admitted under Children's Services. For the majority of 16 and 17-year-olds, they could be treated the same as the older adolescent paediatric population. However, there are a few additional clinical considerations and an ED proforma exists to help you. This can be seen on the next slide. Furthermore, there are a couple of additional legal considerations and we will deal with these towards the end of the presentation. Don't forget though, there's a lot of adult experience in and outside of the ED to help guide and support you with these patients, as until recently, these patients would be seen and treated by those clinicians. There's an overriding proforma that's available on Insight and we'll just deal with specific parts of this in turn. Just like with the older adolescent paediatric population, there are certain topics that we must include when we're taking a history and consider clinical presentations that might relate to sexual activity, alcohol and substance misuse, mental health, and social circumstances such as relationships between their peers, their partners, and their parents. Predating COVID, there are some adult proformas that are really useful and should be used in the management of these 16 and 17-year-olds. For example, the paracetamol poisoning algorithm, which has got adult values on it as opposed to the paediatric version. Please take time to familiarise yourself with the availability of some of these adult proformas as per the overarching guide. In addition to the clinical considerations, there are a couple of additional things we need to think about, and these are listed below. We'll deal with each one in turn. Regarding consent, there could be a whole presentation around consent and capacity, but in reality, most of the time this won't cause you any difficulties. If there are difficulties, as it's such a grey area, consider involving a senior early. Examples of these tricky situations might be a 16 or a 17-year-old refusing investigation or treatment, but where the parents are consenting, or children and young people wanting to leave against medical advice. Can they leave? Do you need to do anything different because they're 16 and 17? For anyone who's interested, there is a more detailed slide at the end of this presentation, and I'd be happy to talk to any of you around the specifics of this group, but the bottom line is, do get help because it can escalate quickly. As I'm sure you're aware, children's safeguarding includes children and young people up to the age of 18. However, the safeguarding factors that affect them tend to be different to that of the younger child. For example, issues around child sexual or criminal exploitation. To check that we've considered these issues, we've developed a checklist to act as a prompt that needs to be completed on all 16 and 17-year-olds called the ED Young Person Safeguarding Assessment. This is a screen that's embedded in the assessment processes and generally is completed during the time of initial assessment. However, sometimes that's not possible, so it's worth knowing what it looks like and how to fill it in. It really is very self-explanatory, and it will tell you at the end that if any of the answers are of concern, that you will need to complete an A form, and it automatically generates an A form task in the taskbar. Alternatively, if there were no concerns that arose during assessment, but you feel there might be something that you'd like us to know about within safeguarding, please just complete an A form as you would for any other young person. And finally, there's mental health. CAMS are a service that see children up to and including the age of 18, so there's no difference in the referral pathways to these services than there is for the younger paediatric patient. Since COVID, all children's services have agreed to take patients up to the age of 18, and the referral process is the same as for the under 16s. Occasionally, though, a young person will not be appropriate for a children's hospital service. This could be due to their presenting complaint. They may already be known to an adult service, or it may be because their behaviour in the department is not deemed appropriate for a children's area, for example, if they're under the influence of drugs or alcohol, or are violent or aggressive. Ultimately, in order to safeguard the other paediatric patients and to place this patient in the most appropriate area, the children's ED doctor in charge or the children's hospital consultant can refuse an admission to a children's inpatient service. And in that situation, these young people will be admitted to an adult area, and how to do this can be found on the proforma. As mentioned earlier, this slide details a little bit more information around the tricky issue of consent and capacity, particularly in the 16 and 17-year-old population. There's good GMC guidance around these issues in the following document, as well as including a section on confidentiality. The overriding principle is that the doctor must act in the best interest of the child or young person. Treatment can be provided to any child or young person who gives consent, provided they have the capacity to do so. Under 16, this capacity is known as Gillick competence. However, in law, anyone aged 16 or over is presumed to automatically have capacity and therefore can consent to or refuse treatment without any parental involvement. In the under 16 group, if a patient is lacking capacity, a parent can consent on their behalf, and that lack of capacity can just be due to the age or maturity of the child, although there can be other factors. Consent only needs to be provided by one parent. But what about the over 16s? Capacity is covered by the Mental Capacity Act, and lack of capacity is determined by a two-stage test. The first stage is there an impairment of mind or brain, either by illness or an external factor such as alcohol or drugs? And the second stage of the test is that if there is an impairment, does this impairment affect them at such a time when a specific decision needs to be made? Anyone who lacks capacity can be treated if it's in their best interests, and there are several factors that need to be considered regarding what is meant by in their best interests, which include factors such as previous wishes, religion, culture, and parental views. So as you can see, this is a tricky area, and it's definitely worth having a senior support you with these patients. Also, don't forget the hospital is full of experienced practitioners who until recently looked after this group of patients. So there's loads of help out there. Don't struggle on your own, and we'd be happy to help where we can. I hope this presentation has provided you with a little bit of reassurance that they're really not that different to your older paediatric population, just with a couple of additional things to think about. Thank you.